So we'll first come to definitions. The basic definitions involved while discussing anuria is first is oliguria. It refers to a reduced urine volume, and reduced in the sense over 24 hours, only 400 ml or less of urine output is observed, or it is less than 6 ml per kg body weight of the person. The mechanism or the pathology involved here is that the kidney concentration is impaired, which results in poor filtration of the body fluids, and a fixed specific gravity of the urine is 1.010, even when uh, the volumes are high enough. So the definition that the output should be less than 400 ml is not exclusive. Even when the pathology increases or the kidney is damaged further, we see that the urine output may be increased to 1 liter or 1.5 liters per day. However, the urine has now a specific gravity which is fixed to 1.010. Another term in this discussion is acute kidney injury, AKI, or acute renal failure. So, to avoid the confusion, they introduced this term acute kidney injury, which refers to the decreased glomerular filtration rate, which is suddenly reduced. And there is sudden retention of endogenous and exogenous metabolites, thereby reducing the volume output of urine to less than 400 ml per day. As I mentioned earlier, there could be a high output or a non-oliguric renal failure discussed here, that the output may be more than 400 ml. However, the kidney function is not uh, correct. Coming to anuria, which the topic of discussion is for today, it refers to complete shutdown of urine output during the acute kidney injury. So, we'll discuss the types or causes of acute kidney injury or acute renal failure uh, on this diagram. Uh, this is a, you can see the urinary system, blood supplying from the abdominal aorta, and the venous drainage from the renal veins into the IVC. So the causes or the types, as we classify acute kidney injury, could be any guesses, any suggestions as to how do we classify acute kidney injury? You can type it down if you are listening and awake. I'm audible, right? So, anyways, I'll continue with the class. So, the first type is pre-renal. This involves a decreased blood flow to the urine, to the kidney, which may occur in a case of shock when the patient is dehydrated, or if there is sudden interruption to the renal blood flow due to any infection or illness. Uh, Another condition is that the cardiac output is reduced, and also there is a sudden fall in the blood pressure of the patient. The next type is intrarenal. So, intrarenal acute kidney injury refers to the changes or the pathology occurring in the kidney. These could be specific, which includes glomerulonephritis, interstitial nephritis due to some toxin, dyes, or hemolytic uremic syndrome. This can also be non-specific, such as acute tubular necrosis and acute cortical necrosis. So we'll discuss it in a little detail further down the presentation. So last one is post-renal. It's based on the site of pathology. Post-renal causes include the presence of calculus within the ureters or the urethra or the bladder, causing an obstruction to the renal flow. There could be bilateral ureteral obstruction, outlet obstruction, as we usually say, bladder outlet obstruction, which most commonly in male, in an elderly males, we see the benign prostatic hyperplasia as a cause of that. They can be leak after a traumatic injury, after a nitrogenic or due to a nitrogenic cause. It could be post-traumatic. After a road traffic accident, we could see urethral injury due to which the patient goes into urinary obstruction. So these are the causes pertaining to the site of the obstruction, site of the pathology, not necessarily obstruction, but site of pathology. We also have several miscellaneous causes. These include functional or hemodynamic. This is administration of ACE inhibitor drugs. If a patient is persistently taking ACE inhibitor drugs or non-steroidal anti-inflammatory drugs, calcineurin inhibitors like tacrolimus, or also seen in cases of hepatorenal syndrome. Then you have vascular causes, which include atheroembolism, dissecting arterial aneurysms, and intrarenal, post-renal, based on the site of the pathology. And then we have several other causes which I've mentioned on the left. Okay. So go ahead. Um, you're all able to see the screen, right? Hello. Am I audible? Okay. So discussing pre-renal kidney injury, uh, what is involved here is there is inadequate renal perfusion or a lowered arterial circulation, which results in low flow to the kidneys. The most common cause is dehydration, which could be due to diarrhea, vomiting, or excessive usage of diuretics. And less commonly, we see patients during septic shock or third space loss, such as in acute pancreatitis or excessive use of antihypertensive drugs. Clinical findings in cases of pre-renal kidney injury is that the patient may complain of thirst or of dizziness in the upright posture, which is also known as orthostatic dizziness. This is one peculiar symptom of a patient of acute kidney injury due to pre-renal causes. There may be weight loss due to dehydration, due to hypovolemia. The skin turgor may be decreased, You may see collapsed neck veins, dry mucous membranes. So these are symptoms of all of these are symptoms of a patient in dehydration or hypovolemia. You may also observe an orthostatic postural change in the BP, which is defined as a difference of more than 20 millimeters of mercury. Uh, Systolic BP drops by more than 20 millimeters of mercury, more than 20, and the diastolic is more than 10 in the standing and lying down position. So this is also characteristic sign of a patient in hypovolemia or a pre-renal kidney injury. If you were to evaluate or investigate such patients, you will find that there is low volume urine output. Measure or a precise or accurate measure uh, of the urine output could be that you catheterize the patient if he has presented to you, and you take hourly output noting that these days we have those Euro bags with a marking which can enable you to note down the hourly urine output. Uh, Plus, the specific gravity is rather high. It is more than 1.025, and the urine osmolality is also more than 600 milli osmol per kg body weight. So, if we carry out a routine microscopy, you will see bland sediments under the microscope. However, when you suspect an acute tubular necrosis, you may also see muddy brown cast in under the urine and blood chemistries. If you were to carry out a blood serum sample, you would see that the blood urea nitrogen to creatinine ratio is 10:1. The patient obviously will have a low venous central venous pressure. There'll be hypovolemia. Uh, so what you can do to evaluate such a patient is give a fluid challenge of 300 to 500 mLs of a normal saline or ringer lactate. And if you see an increase in the output of urine after the fluid challenge, this is also diagnostic and therapeutic for pre-renal kidney injury. If you see that the urine output is more than 50 ml per hour, this is a favorable response, and you should continue with intravenous infusion of crystalloids at this point so that you can actually treat the patient as well as once you've made the diagnosis. So as I mentioned earlier in the previous slide, you correct the fluid losses if the patient has oliguria and hypotension exists. You give IV fluids, and despite IV fluids, if you see that if you measure the central venous pressure and you still have a high central venous pressure, that means the body is well hydrated, and it is an indication to start vasopressor drugs, especially which are indicated in cases of sepsis and cardiogenic shock. So you have to think again that uh, that what you're treating here is actually a sepsis or cardiogenic shocks rather than a hypovolemic hypotensive patient. So earlier days they used to say that dopamine in renal doses, that is 1:2 or 1:5 microgram per kg per minute, was effective. However, recent studies have shown that it actually has rather poor side effect profile. So they have introduced a drug phenoldopam, which is comparatively better than dopamine. You should always ensure that you discontinue any antihypertensive or diuretic at this point. If you have any questions, you can probably type it down and I'll revert to that later. Or maybe you can keep a note of it, and then during the question session, you can write it down. Coming to intrarenal kidney injury, specific types. So these include an acute or rapidly progressive glomerulonephritis, acute interstitial nephritis, toxic nephropathies, and hemolytic uremic syndrome. So again, we come back to that slide. This is we're discussing the intrarenal causes, right? We have finished with the pre-renal. Intrarenal are specific and non-specific causes pertaining to the kidney. So clinical findings, we often find that there is a history of sore throat or upper respiratory infection, diarrhea, any administration of recent antibiotics or IV drug abuse. The patient may present to you with bilateral back pain, cross hematuria, or it may be associated with systemic diseases like Hinox, condylar purpura, SLE, and HIV-associated nephropathy. If we do a lab workup, we find that there are red or white cells in urine routine microscopy, and multiple types of cellular and granular casts are visible. Blood investigations reveal there is a decrease in serum complement, and there may be circulating immune complexes or antibodies in the system. Okay. Then, if you were to plan a renal biopsy, you would see characteristic changes pertaining to the disease that has occurred. Suppose characteristic changes of glomerulonephritis, acute interstitial nephritis, HUS, immune deposits in rapidly progressive glomerulonephritis. Depending on the site of the deposits, we can say whether it is lupus, post-infectious glomerulonephritis, or IgA nephropathy. I'll not go into much details about these because we can probably discuss them in medicine or another subject in pathology also. So treatment involves that, first of all, you should remove the injurious agent. You must address the cause, which is resulting into kidney injury, whether it is infection, antigen, toxic drugs, and materials. So this is the first step to avoid further damage, and then you work on improving the already damaged kidney. So there should be suppression of the autoimmune mechanisms, removal of autoimmune antibodies, and a reduction in effective inflammatory responses. These can be done with the use of drugs, most likely corticosteroids, and if required, plasmapheresis. A supportive dialysis may be indicated. Coming to the non-specific types of kidney injury, these include acute tubular necrosis and acute cortical necrosis. The latter has a poorer prognosis, which also involves intrarenal intravascular coagulation. So the findings in such a patient is that the patient is in dehydration and shock, and despite giving the fluid challenge, there is no increase or improvement in the urine output, which is in contrast to a patient of pre-renal failure. The patient may also present to you with excessive fluid retention. Laboratory findings, the urine will have a specific fixed gravity, as I mentioned earlier, between 1.005 to 1.015. The osmolality will be low here, less than 450. And you may see tubular or cells or granular casts on a microscopy. The urine may be muddy brown, and in cases where the urine is heme positive but you don't see any red cells, you can consider the diagnosis of pigment nephropathy. The CVP may be normal here, and despite giving fluid challenges like intravenous mannitol or NS, you will still see no change or increase in the urine output. What is effective is, or if you give furosemide or renal dopamine dosage, it's rather not effective, but it is sign. If you administer furosemide and renal dopamine, the low urinary output is converted into a high fixed urinary output. So it does not improve the kidney function, it just improves the urine output. So the treatment here is, if there is no response to initial fluid and mannitol, you have to curtail the fluid to noted losses. You really have to be sensitive about how much fluid should be given to the patient, and that you calculate based on the urine output. And there should not be any extra fluid administered to the patient. So you get the serum creatinine and blood urea nitrogen on serial basis. You should maintain a calorie of 30 to 35 kilocalorie per kg body weight, because the patient may end up in a catabolic state. If the patient develops hyperkalemia, you have to do the following: that you administer sodium bicarbonate, you get an ABG done. There is an option of giving K-Exhalate with the dosage of 25 to 50 grams. In cases where you suspect there is maybe the potassium levels are quite high, you give intravenous glucose and insulin and intravenous calcium to stabilize the heart, because there is always a risk of damaging the SA node with such high potassium levels in the body. So these are all the things that you actually will be doing in the wards, which we have done, and to manage a patient of hyperkalemia. So you must prevent then contrast-induced nephropathy if you suspect that the pathology is because of contrast. You administer sodium chloride, 0.9%. You give sodium bicarbonate, and acetylcysteine may also be effective. And if required, you carry out a hemodialysis. You also have to correct the uremia, hyperkalemia, fluid overload, and for that, you may require a peritoneal dialysis or a hemodialysis. So prognosis in most cases is actually favorable. The pathology is reversible, and within 7 to 14 days, a week or two, if you do manage the patient well, he may recover quite well. So coming down to post-renal kidney injury, this is actually the most important part for a surgeon. You can see the causes include calculus, bilateral ureter obstruction, outlet obstruction, any leaks, or after a trauma, right? So it may be discovered or observed if there is after a lower abdominal surgery. If you see, it could be because of urethral or ureteral obstruction, urethral or bladder neck obstruction, and the causes, as I mentioned earlier, mainly surgical. So there is a tumor which has developed there because of the mass effect. It is either compressing on the ureters or involving the ureters or causing retroperitoneal fibrosis. We can see that in a case of retroperitoneal sarcoma or a uterine pathology, a uterine tumor. If there are renal calculi in both the kidneys, they may get stuck in the ureters and obstruct distal urine flow. Or if there is any trauma, either because of a surgery or because of a trauma otherwise sustained, possibly maybe because of an accident. In cases of a solitary kidney. If the patient has only a single kidney, the ureteral stones may result in total urinary tract obstruction and AKI. This again shows the location, the site of the pathology. In these patients, what you find is there is pain and tenderness over the costovertebral angle. There may be urine leak if you have done an intraoperative injury of there will be edema from overhydration, and there may be ileus with distension and vomiting. Lab findings, once you actually treat the patient, if you suspect a post-renal kidney injury, you must attempt to insert a urethral catheter, which itself is diagnostic and therapeutic. X-rays have a limited role, but radionuclide renal scans may reveal a urine leak or a site of obstruction. Cystoscopy is indicated when you actually suspect an injury or a disruption in the distal urinary system to confirm the diagnosis. There could be a stone, there could be a tumor in the bladder, which is causing an obstruction. So these were the causes of kidney injury pertaining to the site. We'll move on to the causes because of vascular system. It could be an atheroembolic disease, which results in renal failure, a dissecting arterial aneurysm, or malignant hypertension. What you may see in such a patient is signs of peripheral atheroemboli. There could be a Pluto syndrome, a transient ischemic attack, a stroke, a mesenteric ischemic pain, or a livedo reticularis. Laboratory findings reveal peripheral eosinophilia, hypercomplementemia, and a renal biopsy may show cholesterol cleft, which is diagnostic. Treatment part, there is nothing much you can do, but except reducing the risk for further embolization and pursue supportive care. Statins, however, have been shown to have some role. So, this is one of the topics which actually is of concern to the surgeon. So, we'll discuss this in a bit more detail. So, a patient of urinary retention may have acute urinary retention or chronic urinary retention, or there could be also acute on chronic. What urinary retention means is that the patient is unable to pass an adequate amount of urine voluntarily. Mostly men are affected, and the causes include either obstructive due to BPH, which is seen in more than half of the patients. Clot retention is also a cause, post-surgical intervention or otherwise. Then there could be infectious, inflammatory, iatrogenic, and urologic. I will not be going into much details because we have limited time. I'll just briefly touch upon the definitions. The acute urinary retention patient would present to you in an emergency setting. There is sudden inability to urinate with suprapubic pain, bloating, urgency, and distress. So you must intervene urgently in these cases. A chronic urinary retention patient is often asymptomatic, but there may be a very large bladder if you were to do an investigation like an IVP or a CT urography. And the patient, however, has no symptoms. Acute on chronic is the patients who have lower urinary tract symptoms. They may go on to develop an acute retention on the background of chronic retention at a point where the prostate in most patients actually causes no more urine to pass through the urethra. So such a patient may actually be asymptomatic, otherwise in the pathology more advanced, and he may land up in the emergency. There are an exhaustive list of medications. So I've mentioned a few, haven't mentioned all of them. And the patient may also end up in urinary retention after a surgical procedure. So the management involves inserting a Foley catheter. On the left side, you see a Foley catheter. There are two ports, one for urinary drainage, the other for inflation of the balloon. And on the right, you see that the tip of the Foley rests within the bladder, and the inflated balloon does not allow the Foley to actually come out. Uh, in case you are not able to establish a urethral catheterization, you do a suprapubic catheterization, in which you give an incision in the suprapubic region, and often when the bladder is distended, it is quite easy actually. Once you go down, dissecting through the abdominal wall, you reach the bladder and you insert a Foley in where there is blockage of the urinary tract distal to the bladder. So, furthermore, once the patient is catheterized, in the follow-up OPD, you can ask for a Foley-free trial. After a SPC, you attend to the pathology which has resulted in obstruction of the distal urinary tract. If you establish the diagnosis of BPH, then TURP is indicated, which is transurethral resection of the prostate. And you also have an entity called clot retention, which we often see in clinical practice. The treatment is you insert a three-way Foley and carry out bladder irrigation. There is an instrument called Elix clot evacuator. So once you take the patient inside on an operating table, the procedure can be done under local anesthesia. So this device is filled with a fluid, mostly sodium chloride, 0.9%, and then we push in the fluid, we press the bladder of this device and the clots, and when we let the device open, let the bladder open due to negative pressure, the saline that we have pushed in carries with itself the lots of clots from within the bladder, right? So if you get an opportunity, maybe when non-COVID facilities are open, you can see it in the urology OD. So you should stop anticoagulants and antiplatelet drugs, and cystoscopy is mandated in case your diagnosis is not established. So that was the first part of the lecture. I hope you're all with me still. So we'll just briefly touch upon the various congenital abnormalities of the kidney. So first one is unilateral renal agenesis. There is complete absence of one kidney. It is seen in 1 in 500 to 1,000 births. There is failure of connection between the metanephric blastema and ipsilateral ureters, but it is an autosomal dominant disease with incomplete penetrance. What we see in this disease is there is absence of ipsilateral ureter, ipsilateral hemitrigon of the bladder, ipsilateral testes and vas, and in case of female, ovary and fallopian tubes. So the remaining kidney may be hypertrophic or dysplastic. Right? So this is a diagram of unilateral renal agenesis. You're all able to hear me, right? Hello? Just five more minutes and then finish with the presentation. So you see there is absence of the kidney, the ureters, the vas deferens, and you can see in the CT scan that there is only one kidney, right? Bilateral renal agenesis is not compatible with life. There is pulmonary hypoplasia and peculiar Potter species. The Potter species is characterized by low set ears, beaked nose, prominent epicanthic folds, and downward slant to eyes. But it is usually incompatible with life, and so we don't really expect such patients to survive, right? And multicystic disease is a congenital uh, severe renal dysplasia. The kidney is often a mass of various sized cysts in a loose stroma. It is seen in 1 in 4,500 population, diagnosed usually on a prenatal ultrasonography scan. Earlier, it was treated with surgery. However, these days we follow a conservative approach. There is usually atresia of the ipsilateral uh, ureter and a contralateral BUJ obstruction. So this is how a multicystic kidney looks like compared to the normal counterpart. In cases of ectopic kidney or cross-renal ectopia, there is fault in ascent of the kidney. So it is usually lower uh, than the normal position. The most common anomaly is that the renal pelvis faces anteriorly. And more severe the disease, the more anterior the renal pelvis is. In majority, both kidneys are fused. In cases of cross-renal ectopia, both kidneys are fused and are on the same side. So this diagram shows the variations uh, of cross-renal ectopia. So this is a cross-renal ectopia with fusion. Both kidneys lie on one side and are fused, the inferior pole with the superior pole. In this condition, there is cross-renal ectopia without fusion. Uh, in this condition, there is solitary cross-renal ectopia. So the both kidneys are fused and even the ureters are fused. You see two ureters. This is where both kidneys have actually changed their space, their positions. The right kidney comes to lie on the left side and the left on the right. This is bilateral cross-renal ectopia. In a horseshoe kidney, the two kidneys are lying low and the lower poles are fused. The ascent is further obstructed by the inferior mesenteric artery. Males are more predisposed. It is seen 1 in 1,000 of births. Because of the unpredictable vascular supply, there may be surgical challenges if you were to operate such a case. The kidney of the patient is prone to reflux, obstruction, and stone formation. So this is the diagram of the horseshoe kidney where you can appreciate the fused lower poles. Duplex renal pelvis and ureter. It is actually duplication, incomplete or partial. Unilateral is 6 times more common than bilateral. Left side are more common and females are more predisposed to males. In cases where there is an incomplete duplex, as you can see in this case, it results in a Y-ureter. Complete duplex, you have two separate ureteric buds. In this image, you can appreciate that there is two separate ureters draining the kidney. When you have a normal uh, bud, the normal ureter which drains at the correct side of the bladder trigone, a lower bud, such as in this case, you can see that its entry would be lateral. to the normal side. When you have an upper separate bud, you will see that the insertion site would be distal and medial, which results in obstruction and dysplasia, often ending up in severe scarring. Children may present with vesicoureteral reflex, however, adults may be asymptomatic. So this shows the upper moiety and the lower moiety. In this case, you can appreciate that there is an upper moiety uh, duplicated ureter which travels and drains medially in the trigone as compared to the normal entry. And this is the lower ureteric bud which actually inserts laterally. Okay. So ectopic ureters are always associated with ureteric duplication, are bilateral. Females outnumber males significantly in the ratio of 7 to 1. So it may open either into the urethra below sphincter or in the vagina in cases of females. A peculiar characteristic is that a female patient may say that she voids normally, but there is dribbling as long as she can remember. In males, however, it is patient is continent, infection is common, and in severe diseases uh, where there is atrophic moiety which has drained the kidney, partial nephrectomy may be required. A definitive treatment is always reimplantation of the ureter. So this is an ectopic ureter. You can see that it inserts lower down and even beyond the external sphincter. So ureterocele is important or is rather famous because of a question which arises, which comes in your exams and often asked in your viva voces, that there is a characteristic cobra head appearance, which is visualized here. The rest is that the pathology is there is cystic enlargement of intramural ureter, probably due to atresia. Females are more predisposed. It is bilateral in 10% of population, uh, often associated with dysplastic and non-functional renal tissue. And as I mentioned before, there is a cobra head appearance. On cystoscopy, you see a bulging translucent swelling at ureteric orifice, which fills in empties of urine with peristalsis. So this is a ureterocele on cystoscopy, right? And you will appreciate that it enlarges in size and then empties with a peristaltic wave. Treatment is often surgical excision and reimplantation, and endoscopic incision for the stones uh, is, uh, is a good procedure. However, in cases of pyonephrosis or when the kidney is damaged, a nephrectomy may be indicated. A congenital megaureter is ureteric dilatation with or without obstruction, may be bilateral. Cystoscopy is often normal. And because of such a massively dilated ureter, there is stasis of urine and development of renal stones. There is a Whittaker test which excludes obstruction. You insert or you cannulate the kidney pelvis and you administer fluids and antegradally through the nephrostomy tube, and then you take images. Retrocaval ureter, just to touch upon, is a rare pathology where the right ureter passes behind the IVC rather than on the side. So you can appreciate that on the right kidney, this is the ureter, which is massively dilated. It hooks upon the IVC and then goes medially and then inserts, right? This is also known as fish hook sign. If you do a radiological X-ray, a dye study, you can see here that there is a hook-like formation. So the patient may have a unilateral hydronephrosis. Treatment is surgical. You divide the ureter and you then let the ureter fall on the right side of the IVC. So So this is the last topic for today's discussion, but rather important. This autosomal polycystic kidney disease, multisystemic disorder. You may see renal cysts along with liver, pancreas, and in the arachnoid membrane. It is an autosomal dominant disease and usually manifests after 30 years. However, in some patients you see that it is never diagnosed. The patient never becomes symptomatic enough. Renal ultrasonogram may diagnose the disease in which you have either at least three renal cysts and two cysts in each kidney for at-risk individuals between the age of 15 and 39 years. Clinical features can be divided into renal and non-renal. Just a couple of slides left and then we'll close the session. So the size increases with age in 100% of patients. There is a dull loin ache, or in cases of hemorrhage or passage of calculus, the pain may aggravate and become severe. Hematuria or cyst hemorrhage is seen in 40% of the population. Patient is more predisposed to UTI. There may be renal stones. Hypertension is the most common manifestation, and you see that most of cardiovascular morbidity and mortality is because of hypertension. And the end-stage renal disease, usually the patient is fine till 4th or 6th decade of life. Even 80% of the patients are alive by 50 years. In good kidney function, maintain their function by the age of 50. However, men progress rather rapidly and present at an earlier age with ESRD and require renal replacement therapy. So this is how a polycystic kidney appears as compared to a normal kidney. Extrarenal manifestation of the disease include polycystic liver disease, intracranial aneurysms, and valvular heart disease. Mitral valve prolapse is most common associated pathology with ADPKD. So that was the end of the presentation. We will have a few slides just to wake you up. So those of you who are awake can type the answers or give your what you think is the answer, right? I'll show you several images which were based on the discussion we had now. So, ready? So what do you think this pathology is? This image which I am showing? Anyone can type? No one is awake? Hello?